Okay, and then I think we're probably good to let people in. Are all of our speakers ready? Great. Okay, let's do it.
So a lot with this, my situation.
Hi, everyone. Thanks for joining us. We'll get started here in just a couple minutes. Right. Well, it looks like people are rolling in a little slower. So I'm going to go ahead and kick us off. Welcome to our webinar on innovative healthcare strategies. This is part of our workshop series for the Casey Communities for All Ages program. We are a program of the Mid-America Regional Council, Department of Aging and Adult Services. Just some housekeeping items first. We ask that all participants remain on mute until our Q&A session at the end. We will take questions in the chat throughout the workshop, but we're going to address all of the questions panel style with all of the speakers at the end of all three presentations. At that time, you'll be able to come off mute. As I mentioned, we'll take questions in the chat. We might try to answer them in the chat as we go through. If not, we'll save them and make sure that they are addressed to the speakers at the end. We are recording this session and we will provide copies of all of the speakers' slides following the workshop. So agenda for today, I'm going to give a quick overview of the Communities for All Ages program, and then we'll hear from Hannayd Ruiz with the Mid-America Regional Council on our Community Health Worker Collaborative. Then we'll hear from Mickey Hill and Judy Wood with the CJ Cares program. And then lastly, we'll hear from Victoria Jackson on community care hub models. Victoria is also with the Mid-America Regional Council. Then we'll have about 25 minutes for questions at the end. So for those not familiar, Communities for All Ages is what we call an age-inclusive, interchangeable with age-friendly city initiative. We provide tools to help cities and other local governments recognize their role in supporting older residents. We do this by providing education, technical assistance, and recognition to cities and counties in the region that take meaningful steps to become more inclusive of residents of all ages, and in the process, more vibrant, healthy, and prosperous. Education is provided through workshops. We hold about 3 of these per year. Technical assistance, we provide meeting facilitation. We are kind of the point people for questions, and we also convene a lot of special projects related to healthy aging. We also provide recognition through a structured 3-level program. We give awards to the city or county that achieves those levels, kind of at each level that they accomplish. The framework for the program, our materials are all structured kind of around these 6 key topic areas: public outdoor spaces and buildings, housing and commercial development, transportation and mobility, social inclusion, communication and participation, civic participation and employment. And today's topics will kind of be under the umbrella of community and health services. This framework was developed to help communities respond to a rapid increase in the older adult population. Our program materials are applicable outside of the region and free to use for anyone. You can find those on our website, which I can put that in the chat a little bit later. And then we do provide formal recognition to communities within kind of the 9-county Kansas City area that participate in the program. This is our current list of participating cities. I think we have 25 now. So if you're with a city and you're interested, please reach out to me. Okay, and with that, I'm going to pass things off to our first speaker. Okay, I'll let you get your slides up. Let me pull this up. Okay. So our first speaker is going to be Hannayd Ruiz, the Community Health Project Manager with the Mid-America Regional Council. Hannayd is a lifelong learner and always eager to take on new challenges. As a regional pioneer in the community health worker profession, with over 12 years of experience, Hannayd continues empowering CHWs through advocacy, education, and capacity building. Hannayd's background includes the integration of community health workers into multidisciplinary teams, focusing on addressing social determinants of health and improving health outcomes through care coordination, support, advocacy, health education, and assistance in navigating the complex social and health systems. In her current role as the Community Health Project Manager, she supports MARC's Kansas City Regional Community Health Worker Collaborative, creates and facilitates training for professional development, and focuses on sustainable solutions for CHW programs. Thanks for being here.
Thanks so much, Lauren, and good afternoon, and thank you for inviting us to share more about community health workers. I'm Hannayd Ruiz with Mid-America Regional Council, and in my role as a community health project manager with our Aging and Adult Services Department, I'm able to serve CHWs across both states of Kansas and Missouri. We know that many residents face physical or behavioral health challenges that require support from organizations to access those community resources. We hope that this presentation will help you consider how CHWs working in your community could help support residents get the access and care that they need to improve their lives. So to get started first, kind of more about, do you know about us? Have you heard about us? We can share a link in the chat. We're interested to know if you've heard about CHWs before, especially when we enter a new audience or your current knowledge about community health workers. Also, let us know if this is the first time that you've ever heard about community health workers or CHWs. So we can give folks a few seconds. Hopefully the link is being shared in the chat. You can scan the QR code. And that's our cloud being informed about social services, social workers, social. Thank you to the folks who are submitting their responses. We'll just see what other answers we get. We have public health, food needs, connection, hardworking, absolutely, community, connection, trust. I feel we have quite a bit of knowledgeable folks in the audience today. Holistic, that's a really great response, and resource sharing as well. We have helpful. All right, thank you for sharing that. Empathy. The responses will stay recorded so we can review those later as well. So thank you folks who are responding. If you're still working on that, please feel free to complete that, what you're doing. We'll definitely look at it after the presentation. All right, so it seems like folks might have heard about us before, so that's really great. And for folks who might not know as much, we're really excited to share more. So the American Public Health Association adopted a formal definition for what a CHW is, what we do. We're frontline public health workers. We're really trusted members of the community. We have a close understanding of the community that we live in, who we're serving. We act as a bridge between clients and health or social services agencies. Sometimes it feels like maybe when you're at a clinic or in a hospital, it's a different language being spoken that you've never heard of before, not because you don't speak English or know English, but just a different terminology or how to navigate things becomes so complex. So we really work together as teams with whichever one of our partners might be to create those healthier communities. And we wear many hats. I saw some of the responses being that we were resourceful, and that's very much true. We do have a lot of resources. We wear many hats to be able to help others be successful. And I say that what makes us special, maybe even magical, maybe it's a little bit biased take, but I think we hear that quite a bit a lot from everyone. And there's qualities from a CHW that really adds value to a client's interaction when it comes to health and human services that maybe doesn't exist in other professions. And that's what makes us really much unique. We're from the community, for the community. We have a lot of that lived experience to be able to walk the talk. We saw it in the cloud that people had empathy and creativity as well as resourcefulness. We really strengthen care teams. So working together, collaborating is a huge component of who we are, knowing that you can't do things alone. So let's come together to approach that. We engage clients at multiple points in their health journey. We know that just a one-time kind of meeting will not be enough, especially if you have a new health diagnosis. You need multiple folks to be able to help you address those needs and be able to really address the barriers to be able to have better health outcomes. When it comes to Mid-America Regional Council, since 2016, we've supported the Kansas City Regional Community Health Worker Collaborative, where we focus on capacity building, advocacy, and the sustainability of this profession. The collaborative has representation from a multidisciplinary collaboration of organizations advocating for the advancement of CHWs at a regional level, as well as the state of Kansas and Missouri. So what does our work look like? We have kind of a regional advocacy and outreach campaign to increase the recognition of the profession, promote employment of CHWs by different organizations to improve the client's health outcomes, promote the occupation of CHWs, being interested as a career choice, as well as support from our consultants to be able to do this work. When it comes to capacity building, we have defined core competencies of what our profession looks like, and we share those with the state of Kansas and Missouri. We kind of bring our resources together to be able to work on that. We have formal training and which leads to certification and credentialing, depending on which state CHWs might be working in. And we really try to support with continuing education for both new and experienced CHWs to grow in their career. We know that sustainability is a big component of this profession, a big question as well. So sustaining the workforce and programs, we have a reimbursement toolkit that we've been working on that's structured for a broad audience to have experience with healthcare, or if you're new for that. The goal is to be able to bill insurance companies for services and create sustainable CHW programs and positions. We're also working on kind of the integration of CHWs. So how can folks have CHWs as part of their team? So illustrating different ways of how the CHWs can be integrated, concrete examples of CHWs being a sustainable team member, as well as taking bite-sized information from our toolkit to be able to teach agencies how to bill and being reimbursed for CHW services if eligible. So CHWs provide quite a bit of services. I feel like what we call maybe our scope of practice, and is really being able to have the bridging the gap between individuals and the systems that they serve, being able to engage individuals along health and human services system. There's different models that can be done. So it really depends where you're working, how you're working. It can be tailored, it can be modified. So individual support, where you're able to assist individuals with different goal setting and removing those obstacles. The care coordination, sometimes it's just providing information, linking people to those services, but really the navigation piece, I think, is one of the most important parts that we help folks with. Health and community liaisons, so communicating with different systems, people, again, like I mentioned earlier, sometimes it seems like a whole different language or a different world when it comes to accessing healthcare. So that education piece, so health education is really important to be able to help individuals be successful in their journey. When it comes to advocacy, it might be different gaps and help folks maybe advocate for different needs. It might be teaching a client to ask for their prescription to be changed to something that's more affordable, or letting their prescriber know that they're not taking some medication because of the side effects. So having that voice within their healthcare journey where they feel empowered and are able to have new skills at the same time. So we feel like CHW programs, when it comes to CHW programs, CHWs belong everywhere. CHWs programs can be tailored. CHWs can adapt to the needs of the community. We saw that throughout the last couple of years, whether it's at a school district, they can work at a senior center, maybe engage people in the community to help them find a medical home, working at a hospital or an emergency room to be able to meet with clients and address barriers, maybe help them be healthy and stay out of the hospital, stay out of emergency rooms. So it really depends on what are the needs that you might see and how can a CHW come in and help those. One of the examples of some of the programs that we've seen is a community paramedic plus CHW program. So we know that here in Missouri, Washington County Mobile Integrated Health Network kind of has a team where they have a community paramedic and a CHW go out into different calls. So if I recall correctly from the presentation, this program prevented folks from going to the hospital, especially when ERs were full and hospital beds were limited. So sometimes when you need help, you might not know what to do. And the one thing that you remember is calling 911. So folks were calling 911, needing help, but not necessarily maybe not an emergency, but just overall needs. So being able to combine a paramedic with a CHW to provide services and being assessed by both maybe increase the ability to access telehealth appointments or do those in-home safety assessments, medication reconciliation, care coordination. So I think the results were quite successful at that program. And I think we're excited to hear about a similar program today. So I know that sometimes, you need help, but where do you go? How do you access it is a big question, which is I think why folks were calling 911. And then thankfully this program was able to address those non-emergent needs. One of the things that we have quite a bit is in our classes that we see are pharmacy tech CHWs. So this is more of a dual role where folks are actually both CHWs and pharmacy techs. We have quite a bit of students have joined us mainly from rural Missouri, and they're able to address those gaps in their communities to enhance that patient experience and elevate the patient experience, as well as address health equity issues. So we've had different students who have been both, current pharmacy techs as well as pharmacists who are supervising the pharmacy techs as CHWs, and they come together as a team to be able to be equipped as both and serve as a dual role in their communities. So CHWs can be part of a care team in a patient-centered medical home or engage clients at a clinic. The key is really to help address underlying health issues and barriers to care. This is the value that they add to the healthcare community. Nurses and doctors don't have the time, resources, or skill to connect to a peer level or complete home visits or identify other barriers. We know that folks usually have quite a bit on their plate, so asking a medical provider to add on either a different assessment, more resources is quite challenging, which is why CHWs can really be part of this care team. So whether it's an unsafe home environment or food instability, that's something that, doesn't have to be a nurse addressing it. It could be a CHW who's part of your team who can take care of this. So what can that look like, especially if you're supporting older adults and caregivers? So a client might attend an appointment. The provider says there are some needs that are kind of happening that are impacting their health. So refer them to a CHW for further assessment. And this is where we find out a lot of things that is usually not disclosed in your typical medical appointment, because sometimes there might be fear or shame in the things that we might say. So CHWs might find out that the client doesn't have a fridge to store their insulin, which is why their diabetes might have, those high blood sugars. Or maybe the reason why they are in pain management and their pain seems to not be controlled is because they had a leg amputation and don't have a bed, which is resulting in them sleeping on the ground, which is a really hard surface, especially as someone with chronic conditions and even after a leg amputation. These are all things that our CHWs have seen that if the providers weren't aware of until a CHW was able to assess them, make that connection, build that trust, and we found out more information that it's impacting folks. So it wasn't just necessarily, prescription or the insulin or the dosage, but the other things surrounding people or the part of people's lives that were really making a huge impact in the healthcare. Because if you don't have a fridge, it makes things really complicated. So I think CHWs bring comfort to clients to reveal a lot more through those trusting relationships that we work really hard to build and creating those client-centered plans to be able to follow up and accountability. We know that we're adults, so we tell someone what to do, or if someone tells us what to do, we're not likely to do it. But if we work together, we're addressing, prioritizing, and feel like things are important, we're more likely to complete those goals and get and get where we need in our health journey. Our CHWs being part of a care team means that you can communicate back with whoever else might have access to the same electronic medical record or wherever you're documenting. That way, people can see what's being followed up, what's being worked on, what else is pending. So, really being able to address these needs to be able to help clients be discharged after successfully completing them. And this example is kind of given of what Medicare has kind of seen with their community health integration. So CHWs, I feel, make quite a bit of impact. They're increasing that access to preventative care, improving health outcomes, improving how chronic diseases are managed, while decreasing social determinants of health, health-related social needs, less ER visits, less inpatient visits, or shorter inpatient visits, being able to bring down those costs for healthcare and prescriptions, and decreasing loneliness and isolation, which we know that has been kind of we've seen loneliness and isolation across, I think, all age groups. So that's something that CHWs have been able to make an impact as well. For the effectiveness of CHWs and kind of what does that look like, I think I wanted to show some examples of we're effective, we're magical, and what does that look like and how effective we are. And it could be a little bit different depending on your program. So it seems like UPenn in the randomized clinical trial for 30-day readmission. So people returning to the hospital, they were able to see a decrease from 40% of those readmissions down to 15.2%. So having less people come back to the hospital made a huge impact as they were enrolled in a CHW program. Kentucky was able to see that for every dollar invested in a CHW or be able to train CHWs or equip CHWs, they were actually able to save a little bit over $11 in the kind of study that they were performing. New Mexico's Medicaid managed care clients, within kind of 6 months of someone being enrolled in a CHW program, they were able to see that they were able to save more than $2 million just by having a CHW kind of enrolled, assessed, and kind of having the follow-up and care. So really being able to see the impact of CHWs at different levels, including cost savings. Like many programs, there's always challenges of what that might look like. So long-term sustainable funding, which I mentioned earlier about one of the toolkits that we're working on to find strategies for that, to be able to be kind of a long-term sustainable funding. A lot of times we might have a grant that's 12 months. So when you have a 12-month grant, kind of starting a new program, getting into the way things are running, being able to enroll clients, really get things started, and then kind of wrapping up. So 12 months tends to be a really short period for grants. Grants are fantastic, but I think kind of thinking a bit more long term of what that would look like is kind of one of the things that we are aiming to. Being able to retain skilled and experienced CHWs. I know that part of it, I've been here about 12 years as a community health worker, and that's because I've been able to move into different positions. So kind of how do we translate that to other CHWs who might have that same interest in their career pathway? So being able to support that CHW workforce, we know that CHWs love what they do. They love serving their community every single day, and they bring value and deserve to be valued too. So those career growth opportunities, an example on the screen is kind of what Penn Center put together about having a tiered system for CHWs where you're able to have like an entry level CHW all the way to level 4. And that way CHWs feel like they're advancing within their programs. Oops, sorry about that. Sorry about that. Okay, I was trying to click and scroll. So those are kind of our challenges. And then kind of like what is next for CHWs. So things that we're working on is that reimbursement strategies. Is it, health insurance like Medicaid, Medicare, or blending and braiding resources? For example, I mentioned grants. So maybe a combination. We know that not everyone has Medicaid, not everyone has Medicare, not everyone has health insurance. So how do we bring together those resources and make best use of them? The things that CHWs have asked us for are what we call specialty tracks. So we know that the needs of a Head Start family might be very different than an older adult and their caregiver, which might be very different than someone who has experience with mental health. So having that specialized training for a CHW to feel equipped to be able to serve the communities that they're working with is something that's one of the things that have been requested, as well as a tiered CHW program. So the example that I had before was tiers 1 through 4. We've also seen different organizations where they're able to move into a supervisor role or a manager role. Really depends on what opportunities are being offered. We know that it's important to have CHWs as part of the programs, the development, the ongoing kind of changes to really have their voice and impact, because they're the ones that are directly working with the client, hearing their stories, seeing what's going on, and their input is really important as you're kind of tailoring your programs and changing them along the way. So it's really important for us to be as part of any sort of program at any level. And that concludes what we have for you today. So we can share the link in the chat as well. You can join our distribution list. We usually have updates for our CHW training, any sort of kind of opportunities for CHWs. We'll be working on more, especially reimbursement toolkit next year. So that's something that we look forward to sharing with all of our partners. We also really want to thank and acknowledge our partners who make our work possible here at the Collaborative, which is the Kansas Department of Health and Environment, as well as the Health Forward Foundation and the Missouri Department of Health and Senior Services. Through their support, we're able to offer all of this training open to folks both in Kansas and Missouri. All of our training is free of charge thanks to the support of our funders. So we appreciate the invite for today and look forward to hearing from the rest of the presenters, as well as answering your questions at the end of the presentation.
Great. Thank you so much. I'm going to move us into our next presenters who are joining us from CJ Cares. Mickey Hill is a community paramedic. He's been with CJ Cares for 21 years and has 26 years experience in fire and EMS services. Oh, sorry. He's been with, what is CJC FPD? Sorry.
It is Central Jackson County Fire Protection District.
Sorry about that. Been with CJ Cares for 7 years. He's a licensed community paramedic in the state of Missouri and certified in CIT in the state of Missouri. One second. Hey, Ashlyn, are you able to share your screen with this presentation? Yeah, 1 second. Okay. Okay, and joining Mickey is Judy Wood. Judy is a firefighter paramedic and has been with CJC FPD for 15 years. She served in the role of community paramedic from 2016 to 2019, and then again 2023 to present. She was one of the first 2 crew members of CJ Cares and remains integral to the organization. Thanks for being here. I'll pass it off to you. Ashlyn, are you good to advance the slides? Yes, I'm great. Thank you.
Well, thank you everyone for allowing us to present to you today. My name is Mickey Hill. I'm with Central Jackson County Fire Protection District, along with Judy Wood. Central Jackson County Fire Protection District covers the cities of Blue Springs, Grain Valley, Lake Tapawingo, and then some of the unincorporated parts of our county of Jackson County. We are one of 7 community paramedic programs in the Kansas City Metro. We were the first community medic program. We started in the 4th quarter of 2016. Judy was actually one of the very first community paramedics in the state of Missouri. Right now, there are, like I said, 7 different community paramedic programs within the Kansas City metro area. Kansas City Fire has a community paramedic program, along with Raytown, Independence, CJC here, Kansas City, Kansas, Johnson County MedAct, and Lawrence Douglas County Fire as well. All of our programs are very unique to the specific set of goals that each program has. So we'll kind of talk about a little bit about our program, because a lot of our programs are kind of similar to what everybody else has as well. So we can go to the next couple of slides. You can pass those ones and we'll get right about to the next one. So CJ Cares was born out of need. So for the previous 5 years before 2016, our fire department saw an increase in call volume by 25% each year. During those years, we added 2 ambulances to our fleet at around a cost of about $1 million between the ambulance, the equipment, and the personnel to run that ambulance. We kept seeing the call volume increase. So we decided that we could maybe try something a little bit different out of the norm. Instead of just handling calls and being reactive, we decided to be proactive. So our main program that we offer and our main mission is emergency use reduction, where we try to find our high utilizers of the 911 system and get those folks to kind of go out and assess their whether it's a need, kind of like our previous presenter talked about. Maybe they don't have a refrigerator, so doing some of that CHW work and social working. We also do a fall prevention program, so about 25% of our total call volume here at the fire department. Out of every call that we run, 25% of it is either falls or lift assists. We know that falls, especially for folks in advanced age, can be life-changing to life-altering to even life-ending. So if we can make a little dent in that, that's a big thing for us. We also have a core program, which is the CJCFPD Opioid Resource Education, where we go out and work with our clients that have substance use disorder and try to get those folks into services. We also do plenty of community outreach programs. So I'll give it over to Judy now.
All right. So as you know, I've already been introduced. I'm Judy Wood. As Mickey said, I'm one of the first community paramedics to be licensed in the state of Missouri. So community paramedicine is kind of a newer, I won't say new, a newer thought process or a newer certification level, especially to the state of Missouri. They actually did not have the licensing and all the regulations finished for the licensing until 2017. So the class that I went to was a community health worker class. So it's kind of a marriage of a community health worker and a paramedic. And so when we're talking about our emergency usage reduction program, or our aim for that program is to reduce the number of repeated transports by the same client. The goal with the program is to identify and provide resources to meet the client's need. And it's not just medical needs. So we're talking about people who are frequently calling 911, and typically ambulance services or fire ambulance services, we kind of have a you call, we haul thinking. And that's not working for 911 services, and that's not working for ERs. It's just bogging down ERs, and it was really increasing our load. We were noticing people were utilizing 911 for things that absolutely were not an emergency. So we are there to provide resources for any need that these clients have. The people who qualify for the emergency usage reduction in our program, and again, this is different from other programs, but it is any person who uses emergency services 2 times in 1 week or 5 times in a month. We identify those by just reviewing our 911 runs for our region. So Mickey and I come in every morning and look through all the 911 calls to our ambulance, and just check to see, okay, are these people who are repeatedly calling, and why are they repeatedly calling? We can go to that next slide. We help by contacting the client. Our first contact is generally by phone. We do attempt to make an in-home visit with every person, and that may look different. Some of our clientele are houseless, so that may be we're meeting at a McDonald's, we're meeting at a park, but we do try and meet with the person face to face, whatever that looks like. And again, we are just trying to identify whatever needs this person is having that might be adding to their need for calling 911. So as we all know, Maslow's hierarchy of needs, those social determinants of health are usually part of that equation. So we kind of try and solve those issues first. With our fall programs, it can be something as simple as, our home safety assessment identifies that grandma has 75 throw rugs in her house and none of them are taped down. So we just, tell our client, hey, this isn't really safe and you can either remove them, or we recommend that you tape them down so you stop having these falls. So each client kind of determines what it is we do for the client, and their needs determine that. But if they do accept our help in our home visit, we go to the home, we do a evaluation with them, a full interview. The first interview usually takes anywhere from 1 to 2 hours. And we will do a home safety assessment if they are in a home. And then through that assessment, we're able to just identify any and all needs. And so this can be anything from income needs, food insecurities, education, not understanding their disease process, health education, anything we might identify, and we seek to resolve those. So whether it's Mickey and I educating the patient, or Mickey and I connecting them with other resources within the community to solve their problem, it just, again, it looks different for each client. We are ready. Oh, yep. So the client can utilize our resources if the client is able to utilize our resources without our help, meaning if they're able to just look at a list of resources we provide them, make those phone calls, set up those appointments themselves, we allow them to do that. We enable them to do that. But for some people, that's just not where they're at. So we meet the client where they're at. We will go as far as the client needs. And so if we need to sit there with them to help them reach each of those goals, and make phone calls with them, and if they need assistance, essentially taking care of the resources that we've identified for them that's going to help them stop utilizing 911, then we will then do that. CJ Cares monitors our clients for a minimum of 1 month unless they refuse to engage in our services. And then we just kind of go from there. So once we drop off the resources and we feel like, they're at a good place, if it's a drop off, but once we have that second visit and go over resources, we either set another appointment to make phone calls or start working through goals, or if they think that they can handle it on their own or with the help of their family, then we just leave them there and we check back with them in a week. But we follow them for at least a month to just make sure that everything is good. And at that point, we can graduate them from our program, but anyone can be in our program at any time. I've got a client who has been part of my program for 2 years. So, we don't ever kick anybody loose if they're not ready, if you will. So next slide, please. This will be Mickey.
So as Judy spoke, we do have a fall prevention program. We use those to reduce that number of falls and reduce that risk factor to our community as well. So we can go to the next slide. So who qualifies? It's any client that falls or requires a lift assist for emergency services. So again, Judy and I will go through our calls from the previous day. And then we will examine that call and find out, was this something due to, if it was accidental in nature, they tripped over a curb, or, if they fell out of a tree, that kind of excludes it from our criteria for the fall prevention. These are more that we believe there's something in that whether it was medical related to whether it was maybe just something in their home that caused them to fall. So we reach out to all of those. Again, we look over all of those folks. I'll give them a call. We try to call every single person and try to get them to allow us into their home to do a home visit. A lot of times we can identify that, maybe they are battling an illness, and maybe they're having all the way to septic for them that's causing this issue. So being able to identify those needs. If it's a medical type of issue, we will go out, do vital signs, contact the physician. We can do 12 lead EKGs. We can give medicines, we can start IVs, all that stuff for the doctor if needed at that time. We do have a fairly good size resource list that we've compiled over the years and made some very good contacts within our region to be able to provide those folks with resources that they need. And if it is perhaps a specific piece of durable medical equipment, we have a pretty good stash or a cache of different used DME that we will provide to them at no cost as either a loaner or just give them, and then try to help them get something through insurance as well. Go to the next slide. That is one of our clients that we were able to procure a wheelchair for this lady. This lady we worked with for about 2 years trying to get the proper sized wheelchair. We went all the way to actually getting the company on Medicare fraud because they had initially given her a non-bariatric wheelchair and would not trade it out or would not allow her to get a different wheelchair. So Judy, as well as Beth, that's in that picture as well, worked for about 2 years to get this lady that wheelchair. She was a frequent lift assist. So next slide. Those are different durable medical equipment, things that we do offer. We have beds, commodes, wheelchairs, walkers, hospital beds, canes, you name it, we've probably figured out a way to get it for that person. So next slide. I'll turn it back to Judy.
Lauren, you said we were going to address the questions in the chat at the end, correct?
Yeah, so anything that you can't type to answer, we can bring those up. We'll have about 25 minutes for questions.
Okay. So our core program stands for CJCFPD Opioid Resource Education. We've kind of broadened that a little bit to include any substance use disorder. Our primary focus originally was on opioids, but we really have broadened that, and we we do focus on any and all substance use disorders now. Our aim is to help clients who are battling addiction in any form, and we provide them with resources for treatment, harm reduction, and we not just treatment and harm reduction, we connect them with just any resource they might need within the community. Next slide, please. The goal of this program is to help lower the mortality rate and give our clients the best opportunity to beat addiction and live a happy, productive life. Anyone who is seeking any kind of treatment or harm reduction for any addiction qualifies for our core program, but we also specifically contact those who have overdosed on opioids and or received Narcan from EMS or our local police departments. Next slide, please. So if we find someone who has had an overdose, I'm going to talk about opioids first, and then we'll talk about all the other substances. And our EMS is able to revive them, or police are able to revive them. They talk to the client and ask for consent for us to contact them. And when they give consent, we do reach out to them. At that time, each and every time, whether they consent or not, they are left with a Narcan leave behind kit at that time. So you're thinking this is an emergency call where someone just overdosed. How do you do all that? Usually there's a bystander, so we can talk with the bystander who can provide this information, maybe not just to the patient, but also the patient's family or friend, whomever called 911. But so we talk to them about the core program. We get their consent for them to reach out to Mickey and myself, or for Mickey and myself to reach out to them. And then they're given Narcan leave behind kits. They're told how to use the Narcan, how to identify overdose. And then we also kind of explain to them the laws that protect them in those cases of using the Narcan, and that if the police arrive, you know, no one's going to get into trouble, so that we don't have anybody just running from the scene, leaving someone who might be unsafe. And then we also kind of talk about the breathing barrier device that is in there. So once that education is provided to the family or the patients, then they at least have the harm reduction piece of the Narcan kit at their disposal. Next slide, please. The Narcan kit has a barrier device for breathing. It also has a bunch of local and vetted resources for opioid overdose. And then it does have 2 doses of Narcan in it. And people have reached back out to us once they have received these, and they ask for more Narcan, that there's no max on how much Narcan we would give a person. We will give people an endless amount of Narcan, and if we run out, we know where to get more. So that's the opioid portion, but we do kind of the same thing for any substance use disorder. If someone has substance use disorder, we do reach out to them and ask them if they have any needs. You know, we do try and set up a patient visit with them, or a client visit with them, just to let them know that there are resources out there if they ever do decide that they want help. And there are ways of harm reduction if, you know, if we can provide them that education to at least keep them alive long enough to, if they ever get to the point where they want to stop that cycle of substance use. So, and then another big part of the core program is education, and it's not just education to the client and the client's families and the community, but it's education within EMS systems, police departments, that kind of thing, to kind of break down barriers, break down biases against substance use disorders, and talk to them about Narcan and harm reduction and how important these programs are to saving lives. Next slide, please. I already covered all that. We also work very closely with community mental health liaison. Can you go back to that last slide? I'm sorry. And then we also, Mickey and myself can refer to Epic, as well as the crews. Our 911 crew members can refer clients to Epic, or the patients can be given Epic's contact for self-referral to Epic. But it's a program put on by the Missouri Hospital Association, in which clients or patients are connected with a coach who is in recovery themselves to kind of walk alongside them through their recovery, whatever that looks like. So if they're still using, they work with them in harm reduction. If they are not still using and wanting to stop using, then they walk through that with them step to step. They get them the resources they need. If this is a houseless individual, they will help them look for housing. They can help people get IDs, social security cards. I mean, you name it, they work with the client for that. So Epic's a great resource for us, as well as our community mental health liaison. Next slide, please. Mickey,
Okay.
that's you.
All right, I know we are really short on time, so
Sorry.
I'll spin through this. One thing that Judy failed to mention, she worked really, really hard, and we have gotten through the state of Missouri, we are allowed to do buprenorphine, which is like Suboxone treatments. So if a client with substance use disorder is in withdrawal and wants to get help, we can start doing medicated assisted treatment on scene. So that's a pretty cool thing. We're one of only 3 or 4 departments in the state of Missouri that's able to do that. So real quick on the outreach part, we are pretty involved within our communities. We do a lot with our seniors. We do a lot of community festivals. We've been on countless different types of community committees, as well as county committees. We also are really pushing the CPR portion of a hands-only CPR, as well as American Heart CPR. So right now, about every semester, we work with both of our high schools and are training about 800 kids per semester in getting them a full Heart Saver CPR course. So pretty proud of that. Next slide. Those are just pictures. Next slide. We talked about the durable medical equipment. We can go to that one. Then we include past that one. So we get our referral sources through our fire and EMS crews. We have an app that allows them to contact us directly. We also get referrals from ER case managers, ER staff, hospital discharge. We work very well with the Department of Health and Social Services, as well as home health. And then we do have like our own Facebook page, and we do get community referrals through word of mouth. And then we'll wait for our questions at the end, but there is our contact information. So if you guys do have any questions, feel free to email Judy or I. So we'll be here to answer any questions towards the end. Thank you.
Awesome. Thanks so much. Okay, sorry, we're having some very minor technical issues. Bear with me for just 1 second. Okay, our next speaker is Victoria Jackson. Victoria is an integrated care specialist and the Community Support Network Coordinator for MARC's Department of Aging and Adult Services. Victoria serves as the Community Support Network Coordinator that operates the Community Care Hub for the Community Support Network. MARC's Community Support Network is a regional community integrated health network composed of community-based organizations that are committed to facilitating an array of support services, including care planning, home-delivered meals, transportation, and evidence-based programs for healthcare entities and other providers. She also serves as the leader training coordinator for MARC's Administration for Community Living Chronic Disease Self-Management Education grant for the statewide delivery of evidence-based programs and person-centered supports for the social drivers of health. Welcome, Victoria.
Thanks, Lauren. I'm happy to be here and talk a little bit about the Mid-America Community Support Network. Next slide. So I know a lot of you are likely familiar with Mid-America Regional Council or MARC. MARC's a nonprofit association of city and county governments designated as a metro planning organization for the greater Kansas City region, is also designated as the area agency on aging that serves the Kansas City, Missouri region. And then MARC is, of course, a forum, right, for the region to work together, advance social, economic, and environmental progress. And MARC is also the entity that operates as the Community Care Hub, or CCH, for both the Regional Community Support Network, or CSN, and the statewide Missouri Association of Area Agencies on Aging network. And that's really the work that I'm here and excited to take a deeper dive with you into and talk a little bit more today. Next slide, please. So this excerpt explains the Community Care Hub model, its goal, and how it works. The Community Care Hub model is about addressing health-related social needs, but what makes this model impactful is the community cohesion that's at the center. This means incorporating diverse input from not only community leaders, but also individuals with lived experience, allowing a more inclusive, community-centered approach to priorities, goals, and culture that's truly reflective of the needs of the community that we serve. So because of this, we're really seeing a big push from agencies at the federal level, like the Administration for Community Living and the Centers for Disease Control and Prevention, to accelerate efforts to develop community-wide approaches to addressing social drivers of health and inequities through community care hubs. Next slide. So what are health-related social needs and social drivers of health? Health-related social needs are social and economic needs that individuals experience that affect their ability to maintain their health and well-being. They put individuals at higher risks for worse health outcomes and increased healthcare use. Health-related social needs really refer to individual level factors. So we're talking about things like financial instability, lack of access to healthy food, lack of access to affordable and stable housing and utilities, lack of access to healthcare, and also even lack of access to transportation. Social drivers of health, or SDOH, are conditions in the environments where people are actually born, live, work, play, worship, and age. And they affect a wide range of health functioning and quality of life outcomes and risks, including access to healthcare, education, community resources, and economic stability. So why is that important? SDOH and health-related social needs are what commonly lead to health disparities. So that's essentially different health outcomes, right, for different groups of people. So addressing SDOH and health-related social needs is an important component of efforts to overcome disparities and achieve health equity for individuals and communities. Health providers can take steps to address health-related social needs by understanding the needs of their patients and referring them to community-based services by contracting with a community care hub. Next slide. Our community care hub here in the Kansas City metro area is a community integrated health network that we call the Community Support Network, or CSN for short. That network serves 9 counties across the Missouri and Kansas bi-state metro area by providing community support services like home delivered meals, community care management, transportation, and more to healthcare entities and their participants. Next slide. So a little backstory on the CSN itself and how it came to be. The development of the CSN began in 2016 and has been 8 years in the making. An initial phase of research began in 2016, where we gathered information from area agencies on aging across the country, began considering return on investment studies and healthcare statistics, as well as emerging guidance on, at the time from CMS on SDOH. We can then convene stakeholder meetings to consider regionally specific health-related social needs that our communities facing and the best community integrated health network approach to addressing those needs. It was during this process that MARC and stakeholders recognized that MARC really had the best existing infrastructure to embark on standing up a community care hub model to best support the needs of our community. We also worked extensively with consultants across the country who were engaged in the community care hub space. And in some instances, we worked with consultants that were actually already operating a mature community care hub. And it's these collaborative learning experiences that are at the foundation of how what has now become the Community Support Network. Next slide. During CSN development, we also utilized one slide back for me, sorry. They look similar, a little different. Thank you. During the CSN development, we also utilized a steering committee to refine the CSN standard array of services like home delivered meals, community care management, and evidence-based programs. And we began to develop standardized agreements that could be used for building a strong contractual network. This included standard network partner agreements, subcontractor agreements, business associate agreements, and even data sharing agreements. Then in 2018, we received some initial philanthropic funding, as well as identified and pursued braided funding opportunities, and received an Administration for Community Living Chronic Disease Self-Management Education grant that was focused on coordinating the implementation of evidence-based programs. And also at that time, we began to engage actively with healthcare entities to explore potential contracting opportunities. Next slide. During the CSN's infancy, key initiatives informed our core array of services that would be offered, as well as the pricing for those services and contract workflows and policies. One of these key initiatives was the Veteran-Directed Care Program, which offers person-centered care and community-centered support to veterans. Another was the Missouri Association of Area Agencies on Aging's statewide network of evidence-based program providers that included area agencies on aging across the state of Missouri, University of Missouri Extension faculty instructors, and a strong network of local community-based organizations in a coordinated effort to implement evidence-based programming and that features proven strategies to support health, well-being, and decreased healthcare costs. And our participation in learning collaboratives with others in the community care hub space also really shaped early on the CSN's forming. We, in those spaces, had the opportunity to share information across states and sectors. Next slide. So this slide gives you a visual of how MARC functions as a community care hub. You can see that the CSN really sits at the center of a network of community-based organization partners and serves as the entity that provides a centralized intake from healthcare entities in the form of patient referrals, and then provides centralized referrals, service coordination, training, quality assurance, and even continuous quality improvement for a network of community-based organizations that provide services like community care management, transportation, evidence-based programs, and nutrition assistance. And these services that are offered they vary based on the needs of each specific healthcare entity that the CSN is engaged with and the contracting, the needs of that healthcare entity. So this centralized approach actually allows for data aggregation and report back to the healthcare entities, which is really valuable to them. Next slide. The CSN model allows our community to be stronger together. We develop this symphony of services where each organization is able to do what they do best and do it well. CBOs are trusted by the community to provide community services and have a long history of providing high-quality community support services, while healthcare entities have a different wheelhouse of services. The CSN is the backbone that supports both the healthcare entities and CBOs by managing the administrative burden that CBOs often don't have the capacity to manage it on their own. The CSN supports the establishment of shared measures of success, person-centered supports, and the capacity to meet people where they are, while efficiently managing the flow of resources to CBOs for a strong community. There are a lot of moving parts to coordinating these efforts, but the CSN, as the backbone of this work, supports all of those moving parts and allows them to work efficiently and in tandem to support a beautiful symphony of person-centered supports. Next slide. So this work is not possible without collaboration. We started by talking about community cohesion. We've had collaboration and shared learnings, and collaboration has been invaluable to this work. We have benefited from collaborating under the Administration for Community Living's Community Care Hub, National Learning Community, as well as the Partnership to Align Social Care's Community Care Hub work groups and Health Equity Learning Collaborative. We're currently running a Medicaid pilot that's focused on transforming rural health in partnership with a rural county hospital. And we're working closely with organizations like Health Team Works and the Kansas City Health Collaborative on performance improvement, vision, health equity, value-based and person-centered care, healthcare access, and community network pilots in urban areas. But I just can't stress enough that this work is not possible without our valuable community partners and collaborators. Next slide. All right, so let's take a look at the CSN in action. The CSN's debut program, pilot program, was originally designed in January of 2020 to include healthcare clinic referrals to the CSN, who would then facilitate the implementation of SDOH support services for the participant. However, as we all know, weeks later, the COVID-19 pandemic began, and this necessitated a quick pivot of direction for the pilot. By November of 2020, the pilot launched with a redesign to provide community support for those who tested positive for COVID-19 in the form of outreach to referred individuals and then provision of services like home delivered meals, transportation, and referrals for other ancillary services. Next slide. Just under 10,000 participants were referred into the pilot program, and about half of those participants were reached by our outreach efforts, where a community support specialist was able to facilitate a social drivers of health screening questionnaire that served as a tool to identify social needs in domains like a participant's living situation, their access to food, transportation, their ability to pay for utilities, and even personal safety. And then those screening results could be used to create a person-centered goal with input from the individual themselves. And then finally, based on an agreed upon plan, our community support specialists were able to share applicable resources and support access to community and partner resources to help keep individuals in their homes and in the community of their choice with the highest quality of life possible. It's also, I think, worthy of note that even if individuals may have chosen not to participate in an SDOH screening itself, they still accepted connection to community resources, which is really impactful. Next slide, please. So those community resources that we're talking about are things like home delivered meals, care plan support, transportation, referrals, and referrals to other ancillary services that you see listed here. This was an incredibly successful program, and in 2020, this COVID pilot project was actually recognized as a John A. Hartford Foundation 2022 Business Innovation Award runner-up. Next slide. All right, so just some final thoughts and summary. At the core of the work that we do, the Community Care Hub model, there are three distinct pillars, and those are collaboration, contracts, and quality standards. We collaborate with community-based organizations who deliver services that address health-related social needs of those in the community, and then assist our CBO partners with the partnership process. We provide free training and support, and that training might look like centralized care plan and assessment training to refine motivational interviewing skills, tech support, and really so much more. We work really closely with our CBO network. We centralize contracts to provide cross-network consistency that is very marketable and valuable to healthcare entities and builds trust and accountability between organizations. And finally, we ensure fidelity standards are maintained across our networks by way of uniform policies and procedures and workflows, which in turn allows accurate reporting of valuable information on individuals back to federal, state, and third-party funders. Next slide. We have currently we've certainly had some lessons learned, I would say, over the past 8 years. We've learned that standard contracts are crucial to achieving quality assurance. We've learned that it's really tempting to bite off maybe more than we can chew, but the best approach to this work is to start slow and build over time. We've learned that a network of experienced partners is crucial and that it's important to remain nimble in this space and retain the ability to expand community support services with the network to meet the needs of multiple contracts, as well as to have privacy and security standards embedded in the network. This work is not easy, but it's certainly impactful and truly rewarding. Next slide. So with these lessons learned, it's really been perfect timing that we were selected as one of 20 grantees to receive an infrastructure building grant that is supporting our efforts to take our lessons learned and then turn those into some actionable improvement objectives that will allow us to take an up-to-date snapshot of our community and then convene community-based organizations and stakeholders to help us identify a shared mission and vision for health equity in the greater KC region and revisit our current strategic plan to make updates that are appropriate for the current ecosystem and landscape of health-related social needs in our community as we continue forward with the important work that we're doing. Next slide, please. And so contact information for the Community Care Hub, the CSN team is on the slide and happy to answer questions.
Okay, let's get our, gonna try to pin our people here. Just give me 1 second. Okay. So, Ashlyn, I don't know if you had questions from the chat. I can look through now. We do have a question. I think that was answered. We have a question for the CJ Cares team. How do you decrease fall risk? You're on mute.
You're on
Mickey.
mute, Mick.
Oh, that's better. So we reduce our fall risk by trying to identify those folks early in that lift assist phase, whether it's they're needing extra assistance in the home. It could be that they have an underlying illness that they're not being treated for, all the way up to they are at a point in their life where they cannot take care of themselves in the home. And then sometimes we will help families get those folks in the right housing or the right environment for their need. We also, again, going in and just recognizing, we had a recent client that we were going over for lift assist to get them into their house. So whether that's identifying that need and getting them in contact with accessible living type organizations that can get them ramps made, stair lifts, chair lifts, all sorts of stuff. So it's just really just kind of trying to figure out whatever their need is and then trying to meet that need, if that answers the question.
So I have a question. I think this is for Victoria. Do you provide technical support for community-based organizations?
We do provide technical support for our CBOs that are in our network. We do have to navigate a number of different client management systems depending, those are kind of contract to contract based. And so we offer all of the support and training that our community-based organizations need so that we can, reduce burden on them and increase efficiency to the best of our ability. So yes, absolutely.
Thank you. I think I've gotten all the questions in the chat. If anybody wants to come off mute and ask a question to our speakers, you may do so. Well, you all must have just covered everything. There's nothing left. I have a couple questions that I prepared just to help generate some discussion. So communities for all ages, we primarily target our work towards local governments. So I have a question kind of related to like how could a local government best engage or support your work? And this is to any of the panelists.
Well, we are kind of a local government in a way. Being a fire district, we're able to, we have our own taxing entity, so we don't necessarily work with our cities per se. But we can, surely we have partnered with our cities in different aspects, sort of working with our senior centers and working with the cities on a lot of our agendas.
So if I could pipe in, the goals of MARC, so transportation being one of them in the area. So really just our government supporting the goals of MARC and the aging communities. I think Green Valley. I mean, both Blue Springs and Green Valley have done a good job, but both the cities are on your either bronze, silver, or gold. Green Valley's gold. Blue Springs is bronze or whatever. But I think supporting those goals is important. I would also say, if they found a place, maybe hiring a community health worker at each of their senior centers. It really could take some load off of Mickey and myself. Not that we need to take load off, but I think we could serve more clientele that way. Truly, because we are kind of at capacity, and so sometimes people fall through the cracks. So if we had a community health workers within both cities somewhere, I said at the community centers for the aging, because they have they do a lot for our seniors in our community centers, but I'm just thinking out of box ways that they could help.
Great. Thank you. Victoria, Hannayd, any thoughts? Okay.
Oh, sorry. Sorry, trying to unmute myself. I was going to add to what Judy said. I think it's a really great point saying that there are more people you could be serving if there was more of you. So that's something that I think could be helpful of being able to support programs or sustain these programs through different either initiatives or, how people are built in. We know some local hospital systems might have had CHWs as part of their budget or finding ways to reimburse and support CHWs. So I think that the need is quite there. We've been hearing it a lot from I think we heard it from, especially from caregivers and the folks that their families, kind of like if they had, I don't think they were able to put words into like what kind of services, I mean, who they need to help, but I feel like a community health worker can really fill those gaps. So having that awareness of our field as well as profession, and then being able to sustain it through different, so like I said, blending and braiding resources would be really helpful.
Yeah, and I will just add that, legislature, both at the federal and state level, influences what these programs and services look like at the community level. And so really spreading the word, information sharing, education is really, really important for continuing to make sure that these programs and services remain available in the community and have continued support and funding.
And Victoria is right. Even it goes all the way up to the state level. For us, our service is a completely free service. We have no funding source besides the fire department. We're very lucky that our fire department is able to take us off the floor to be able to provide this service. That's why you don't see a lot of community paramedic programs throughout the state. Is there's no funding source. Plus, there is a paramedic shortage. So being able to take someone off of an ambulance and dedicate them to doing the service is very difficult at this time. So, kind of what Judy said, man, we could get CHWs in every fire department. We'd be doing great.
So my next question is related to kind of the client experience and how a client might access your services. I know CJ cares it sounds like you're looking at your own call data and sort of identifying clients in that way. So this might be more towards Victoria and Hannayd. If somebody was hoping to get their health insurance to cover home delivered meals, for example, or connect with a community health worker, how would a client make that connection? And I know it's probably heavily dependent on who their healthcare provider is, but I think any of that kind of information would be helpful for our audience.
Yeah, it is dependent on healthcare provider right now. Would love, I think, in the future to see the community care hub model available for members of the community to self-direct into our programs, right? Because there are right now, not all healthcare entities support the work that we're doing through this, community care hub model. So so in the future, that would be wonderful. At the time, right now, it's mostly the insurance or the healthcare entity or the insurance company themselves. Programs like Medicare, Medicaid, and if we have contracted with those providers. The providers themselves determine who would be eligible for the programs that we offer, and that is based on utilization and claims data, things like that. So I do want to stress that it's very variable. So we have not had a single engagement with a healthcare entity or a contract that has looked the same with the same requirements, the same eligibility. So this work is innovative and new and changing all of the time. So I think that's what I have to say about that.
Great, thank you.
And for us, so the collaborative is mainly supporting and convening different folks, so not necessarily employing CHWs, which is a little bit different. MARC does have 2 CHWs in our Head Start department, which focus on helping those families. So I think if folks do need to find a resource, usually you might reach out to us, and that depends what you might need. So whether it's, with a community-based organization like the Community Health Council in Wyandotte County, or if it's Johnson County Health Department, I think they have a CHW that attends a public library to be able to meet with the public, or maybe it's one of the federally qualified health centers like SWOPE or KC Care, Sam Rogers, who have CHW programs that might be specific. But I think right now, I feel like it's a little bit challenging. It might be depending on your needs, what you qualify for, what that might be, instead of kind of like a streamline or kind of even uniform style. But if folks do have, I think the more you learn about programs in the area, the more you're likely to be able to refer clients like, hey, this program really, helps with folks who are currently maybe maternal health CHWs or mental health CHWs. So having that awareness will be really helpful. I think that one of the things that we'll be working on next year is maybe having more cohesion when it comes to what programs are available. We do know that the Kansas CHW Coalition does have kind of a list of where CHWs are located in the area, and MARC can also work on updating what those programs look like. Everyone kind of has their own both services, referral style, what they do. So I know that it might be a little bit challenging to keep up with that.
Great, and there was a question for you in the chat as well. Could MARC consider having a CHW organization similar to CHC in Kansas City, which we might, I don't know what that acronym is. If you do, or Sherry, if you want to put that in the chat.
It's Community Health Council. I think Ms. Ruiz was answering that question.
Okay, great. Did we get an answer? I just want to clarify.
I think she said that it was not possible for now, and the resources that are there could be utilized by updating the information that people could have access to, or organizations like CBOs could have access to.
Okay, great. Well, we've got about 4 minutes. So I'm going to go off script a little bit, sorry, to the speakers, but there feels like there's a lot of synergy between these programs, and we haven't really directly addressed that. So I'm just curious on your thoughts after this discussion and what you've learned from the other speakers, like where you see potential maybe future collaboration between these types of programs. If there's anything that's really on your mind, that could be something interesting to kind of plant the seed in this discussion.
I would like to know how Victoria and would consider the PACE programs that are kind of popping up, like Archwell, and I don't know the name of SWOPE's PACE program, but Quantum, these different places. How does that work with the work that MARC is doing with seniors?
Mm-hmm. So the CSN is a community care hub. And so with that model, the CSN would sit at really at the core of those relationships. So we do have a partnership with PACE actually. And so we're able to partner with healthcare entities of all sorts and develop program an array kind of programs and services that support their needs. And so with those relationships, we are able to facilitate that like centralized referral into connection with community-based organizations. So that's how it works, just in, I think, a general overview of how the community care hub model would work in conjunction with any healthcare entity. We are the backbone that is able to connect individuals with community supports. And that's why our community-based organization, our CBO network here regionally is critical. It's crucial that we have a really robust CBO network that can provide those community support services and really start to think as individuals as being whole people, right? We're not our conditions, we're not our healthcare diagnosis. All of these components interplay together. And a lot of our healthcare, our disease outcomes are influenced and determined by social factors, right? Where we live, where we work, the access to healthy foods and services that we have in our communities. And so we really have to start to think about things holistically if we want to see better healthcare outcomes, lower healthcare costs, and all of that good stuff. Does that answer your question, Sherry? Is that helpful?
I was thinking more of how you do that. Like, what do you do for PACE, the PACE program? Like, what is your piece?
We're partnering to provide congregate meals, like hot meals for those meals right now. But that it can look different, right? So we allow healthcare entities to really inform and shape the services that they might want or feel are a best fit for their patients and the people, the communities that they serve. So that gives an example. We could broaden those services just using PACE as an example if that's something that organization were interested in doing. So we could broaden those services to include community care management. We could broaden those to include evidence-based programming, right? We do partner with those agencies and make, like, we're hosting evidence-based programs on site at PACE. And so their members are able to attend those programs and those programs improve health outcomes, improve health and well-being. So we're nimble and agile, but we do have our kind of go-to standard array of services and adjust those as needed to fit the needs of real people.
Would you say they're custom to the particular organization, like you kind of customize each organization you work with?
Yes, often
Okay.
we do.
Thank you.
Yeah.
And Lauren, I know we're at time. I was going to just, if I could, about the synergy and kind of a cohesion question, if that's okay. So I know one of the things that we're doing is like Victoria's presentation on CSN. So what we're doing is kind of working together now on a project and being more strategic of how we're planning this, realizing that, as everyone noticed here, the pattern of needs resources is quite similar. So how do we come together with what our ideas have, what we're seeing, and really, as well as our community partners like CJ Cares, and be able to work on something that can really be able to help better serve our communities as well as increase our CHWs. So that's something that we have plans for, including this month, to see what that looks like. And we look forward to connecting with other people that have programs. I think the importance of being aware of what programs are available and how they're serving clients really helps us deliver that information to others. And that way people can kind of have that network. So building that. So I think that's really important. And I really look forward to connecting with everyone on this call after this.
Great. Any final thoughts from the CJ Cares team? Just want to give you a chance if you got something on your mind before we wrap up. We're good. Okay, well, this was a really great discussion. I just want to say thank you to our amazing speakers. I learned so much about what my own organization does today, so that was really awesome. I really appreciate you being here. And as I think I mentioned in the chat, we will be hopefully sending out the recording, assuming it works. We did have a couple of glitches, but we will definitely share the slides and make sure that you have the contact information for all of our speakers. I will also make a plug. January 14th, we are having webinar on universal design. It'll really be targeted kind of towards local governments and how they can work with their developers on universal design projects in multifamily units. So look out for information on that. Thanks so much.